High blood pressure is very important. Let's call it high blood pressure, not hypertension, okay? Because patients don't understand hypertension, but everybody understands high blood pressure. So, there we are. We spend ages fiddling about in the cath lab, don't we? The stents and whatnot. And non-fatal, the patients, they go out and they walk home and they're fine, and they go to rehab. A non-fatal stroke's a catastrophe, so while we're here to prevent MI, of course we are, and treat it, let's not forget about stroke, because it is, from a patient's point of view, the big disaster. Now, how many members of the ESC got? Anybody? Who wants 96,000? Me. It's 96,000, all right? How many papers are presented last year? Who wants 3,000? 4, 5, 6,000. There were 6,626 papers presented. And what proportion involved hypertension? Anybody? 15, okay? So it's a big deal in cardiology, and sometimes it doesn't get the recognition that we should all give it, because it's very important, and there's an awful lot of it about. Which is the, I show this every year, and so many of you get it wrong every year. Which is the most important risk factors of all risk factors, okay? Who wants smoking? It's got to be smoking, hasn't it? Diabetes, John. Hypertension. Oh, a few hands. It is, of course, hypertension by miles, said the WHO. Okay, blows away everything else because of stroke and kidney failure. All right, and heart disease and heart failure as well. So worldwide, hypertension is the big deal for cardiovascular disease. Yeah, smoking, cholesterol, that's important too. So we have to learn about it. Those of you who are doing your exam, this is what JRC-PDB says. You've got to know about it. Knowledge of causes, investigations. I'm not going to go through all of these in the talk, but it's important for the exit exam in cardiology, so you need to know a little bit about it. Now, I'm going to show you how the trials and how the targets have evolved over the years, and we've ended up, you see, year on year, we've got lower and lower. Europe, we tag along behind the Americans, and Europe and America both are now down at 130/80. Nice. Just a few months ago came out and said they're going to stick at 140/90 as the target for the UK, or 135/85 if measured at home or using ambulatory monitoring. So that's fine. So very aggressive targets. You see how we've got more and more and more aggressive over the years to try and reduce stroke and heart disease and heart failure and so on. So there's a target. In the UK it's going to be set at 140/90, which is modest, but there we are. So here's a patient. 17-year-old lady, 175/70. Now, who wants to lower that blood pressure to 140/90? Anybody? I'd like to. Well, let's see what happens. That's her sitting down. Let's stand her up, and it drops to 149/50. Very typical. See this all the time. And see if you'd lowered it at the start, she'd be tumbling down the stairs with her postural hypotension. So you've got to be careful. Now, where is this? Krakow. Yes, well done. Why am I showing a patient from Krakow? Well, this is a patient of mine who was on a pilgrimage to Krakow, right? And she had a collapse, a loss of consciousness in Krakow, and she was brought by her daughter, who's Scotland's leading advocate, and said, "Fix my mother." Anyway, so she was on... So don't muck it up, all right? So on loads of drugs, okay, and yeah, drugs are important. We want to lower blood pressure. We've seen for many, many years, because this is ancient data, the straight line relationship between blood pressure and stroke, and heart disease actually, this one. But there has to be a point when blood pressure is too low. And so I'm going to make these J shapes and see how those fit the points. So there has to be a point when blood pressure is too low. Got to be, because you have to supply your brain with something. This is Swedish data, followed up for nearly 40 years. Those with the lowest blood pressures do badly, and you're going to say it's because they've got cancer or GI bleed. It doesn't matter what they've got. Low blood pressure isn't good for you over a long space of time. These are 4 different trials, all of them large coronary disease trials, all sorts of things. Everybody with low blood pressure does badly, and you're going to say they've got heart failure. Of course they do. Poor coronary disease. If you've got low blood pressure, it's a marker for doing badly, so you don't want to be too low. This study is hard to see, but just at the red are people with the highest blood pressures. These are older people, average age was 88, I think. In the older people, those with the highest blood pressures do the best. Now, we run out of data at about age 87. That's when the HYVIT trial finished, the finishing age of people in the trial of Prindapol and thiazide versus placebo. So, and after about that age, we're really just guessing, okay? So we're back to Our Lady. There's blood pressure. I saw her in clinic. Waited a wee while. Waited a bit longer and a bit longer. Stood her up, and off you go. So what did I do? 120/40. All right. Well, stopped all her drugs. And she'd had valsartan when she was younger, and she said, I like valsartan. I said, well, I'll give you valsartan, because concordance is what I gave her. The lowest dose of valsartan, and off she went. And so that was 7 years ago, and she's now 96, still on valsartan, 40 milligrams once a day. I saw her recently with her daughter, Scotland's leading advocate, and she's absolutely fine, living in East Lothian, very happy, getting into her late 90s. With what looks like high blood pressure, but actually she's fine. So the point is, don't overtreat blood pressure in older people, because you don't know what you're doing. None of us does. There's no data. What there is data, which I won't go on about, is ambulatory monitoring. And office blood pressure as a snapshot in your private rooms, but what actually the patient has is, of course, blood pressure all the time. So ambulatory monitoring and home monitoring is the future, and that's really it. This is one study which is actually under a bit of a cloud just now. I'll show you a little, in fact, unpublished slide from this. This is 64,000 people followed for many years, just to show you masked hypertension, which is people with pretty good clinic blood pressure and high home blood pressures on their home monitoring. It's a Spanish study. Very large numbers followed for a very long time. They do very badly. So blood pressure at home is the indicator. So get your patients to bring up little charts of what they do at home, and that's important. Now, who's that? Emily? Not me. That's Paul Welton. He chaired, of course, the American guideline. And I'm going to show you a little bit about that, because this is based on the SPRINT trial. Now, this trial has changed practice in cardiology, because it was a trial of aggressive blood pressure lowering versus pretty good blood pressure lowering. You see the achieved blood pressure is really quite low in the intensive group, at 122 systolic. And did that have a benefit? Well, yes, it had a very large benefit. You've seen all this before. This is quite old now. Very large benefit in cardiovascular endpoints. And in all-cause mortality, again, this is what stopped the trial early, because there's 27% relative risk reduction in all-cause mortality, which is terrific. And so this has transformed blood pressure, hence the low guidelines. Now, if you make the chairman of the trial the chairman of the guideline committee, because Paul chaired the guideline committee as well, you're always going to get this guideline. So it has been a bit criticised that it's maybe a little bit too aggressive. So in the UK we actually haven't gone as far as them. Anything else? That should be a video, doesn't matter. We know this, but most general physicians, GPs, don't know this. There's atrial fibrillation. I did this in the cath lab when I was still in the cath lab those days. Cardiac output here with an aortic catheter. There's some there, there's some there. No cardiac output for those ECG complexes. Yeah, we all know that. But a lot of physicians don't. And blood pressure machines don't either. So that when you're measuring blood pressure, and the automatic machine will record that one, because it's the highest one, but the patient lives on an average down about here. So automatic machines will not work in AF. You have to do it manually, all right? Automatic machines they'll always overread. Now, let's talk a wee bit about, I love diet and stuff like that. It's always fun. Weight loss, yeah, we all know about that. Heart-healthy diet. I'll come back to the DASH diet. Sodium, yeah, a bit more potassium. Potassium supplementation gets a 1A, and I reviewed the American guideline. I said to Paul, how did you get 1A? He said, oh, well, we got 1A. Which is what he said. So they said, yeah, it's supplemented, 1A, which means, big randomized trials. Europe says, well, we might give it a 2B, potassium supplements. NICE says, do not offer potassium supplements, all right? All based on the same evidence. So what are we going to do? Let's do a trial. Now, I did this with Channel 4. I must publish it. I haven't published it yet. I showed some of this before. And this is a trial of porridge versus coconut water, rich in potassium, versus beetroot juice. Hands up those who've had beetroot juice. A few. For those of you who haven't, it's like putting your face in soil and sucking, okay? It really is, personally, not very palatable. Oats, we'll go up with that. Coconut water, who's had coconut water? It's expensive and kind of trendy. Let's show you the data of coconut water. Coconut water did nothing. I'll whiz through this. Beetroot juice, likewise, perhaps because of concordance. Porridge the big winner, because, as John News told us, if you slow your absorption of carbohydrates, which is what porridge does, you reduce your insulin, and insulin drives blood pressure. So if you're going to have dietary supplements for blood pressure, oats is very good. So there you are, and that was on Channel 4 last year. Now, how much salt should we consume per day? Hands up. Who wants 7 to 10? I do, because it's a brilliant diet. It's bacon and crisps. And actually, it is, of course, 3 to 5 grams. So that's based on the DASH diet that we all quote and know. Now, how long did the DASH diet last for, the study? Who wants 4,000 patients for 12 months? 1,200 for 6. You've got to make a guess. 600 for 90, 400 for 30. Nobody knows, do you? We all quote it, and nobody knows. It was done for a month, all right? 400 patients for 4 weeks, and we based every guideline on this one rather small, very short study. I mean, there is a relationship between blood pressure and salt. This is from UK Biobank, 320,000, massive amount of data. And for every quintile of salt intake, your blood pressure goes up. Whether that is related to outcome, we don't yet know, because that's a long follow-up, but we'll see. Anyway, back to diet. Exercise. Hands up those who take 30 minutes of exercise 5 or more times per week. So there's a big queue at the confessional tomorrow. Really? Okay. Avoid binge drinking, blah, 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 and all that stuff. I'll show you this. We just published this. This is a nice study. What's the common factor here? They're all sugar, aren't they? They're all made of sugar. And if you reduce sugar, you reduce insulin drive. John, isn't that right? Yeah, see, we're all diabetologists. It's dead easy. We published this study. Scott's lecture this afternoon, I hope he talks about it as well, and in general practice, in people with diabetes, and we reduced the carbohydrates. We use a chart like this. See how much carbohydrates in basmati rice? Tons of it. Frozen peas, very little. Apples down there. I learned an awful lot in this study, honestly, because as cardiologists, we don't think about this. Anyway, if you reduce carbohydrates, you get all sorts of clever outcomes. We did this 2-year follow-up study. I'll just show you the results. Big fall in cholesterol, weight came down a lot. Blood pressure came down a bit. But that's the benefit. We had to stop therapy in a third of patients because it fell so low. So actually, for people with diabetes, John, you might use this in your clinic, low-carb diet, profoundly effective. So think about that for your people who've got diabetes. Now, everyone likes tables because these come up in exams. Secondary hypertension, I'm not going to go through these at all. Obstructive sleep apnea, that's getting bigger and bigger, but the interventions aren't proven yet. And all the rest of them, you've seen all of those in endless textbooks, including mine. What do we do? This is what we do at the Mayo Clinic. Basic test using these and so on and so forth. Catecholamines, albumin-creatinine ratio, home or ambulatory monitoring. Everyone younger being under 58, gets renin, aldosterone, cortisol, and we don't use ultrasound anymore because it's pretty useless. MRI angiography across the board to see the state of the kidneys and renal arteries and adrenals. And so that's the baseline set of investigations that we do. Concordance, because you have to establish concordance. How do you do that? Well, I'll show you. Patient referred to me, chosen every drug you can get practically, with high blood pressure. And so bring her up to clinic, give her her own tablets, right? Witness tablet taking and stand by. Okay? And she collapsed in the hospital, shocked. This happens again and again, honestly. You then have an informed discussion and say, just take the thiazide, okay, because you're taking nothing. Now, nice. This is just out, so you have to see this, I suppose. Clean your blood pressure, check it at home. You can look at all this on the nice website. It's endless, so there's nothing really new here. A decision, patient aid. I want to go on to some interesting stuff. What about drugs? We'll come on to this in a minute. I've mentioned ACD, which we all know. What do you do beyond that? Well, this is pathway 2, which is people who are established on an ACE inhibitor or ARB, calcium channel blocker, and diuretic. What about COVID-19 and angiotensin receptors? Anyone read this? That the COVID-19 virus binds to the A2 receptor. Now, if we take losartan and have loads of angiotensin racing about doing nothing, it might block the virus. That occurred to me the other day. So we'll see. I just put that. That's not in the slides. Anyway, what was in the slides was this trial, Spiro versus bisoprolol and doxazin and whatnot. And you've seen it before. Spiro is much more effective than other drugs when you're adding it on top of triple therapy. So you want to add a drug, add Spiro. But in my experience, it's quite difficult to use. I'm not a big fan of it, even though the guidelines says it, all right? Because unless you've got perfect kidneys, they'll be okay for a while, and then they'll go into some AKI and develop acute renal failure and be catastrophic. So it's a difficult drug to use, even though the guideline recommends it. Amiloride is almost as effective and much easier to use. So I like amiloride as an add-on for people on 3 or 4 drugs already. What I'm beginning to use, John, I'm beginning to use SGLT2 inhibitors. I'm using DAPA, lithosin now, in people who haven't got diabetes with informed consent, because it's a brilliant drug for severe hypertension, because they've all got edema. This gets rid of edema, lowers their blood pressure, their kidney function improves, so that's coming our way very soon. It's not licensed yet, so it's not on the slides, but something that I'm doing in clinic now is to use dapagliflozin for people with hypertension who haven't got diabetes. So down here, this is this area here, more resistant hypertension, check it with home and ambulatory monitoring. Spiro you can do, but I don't like it very much. Alpha blockers, yeah, you always get edema. Beta blockers are quite good sometimes. I think SGLT2 inhibitors are going to find a place there as well really quite soon. How are we doing for time, John? Another wee bit. Yeah, a wee bit about intervention, because we love intervention, because we're all cardiologists, and you've got to get catheters in. So this cartoon has caused more trouble than almost anything, because if oh yeah, I can get in there, that's the order. I shove a catheter in, zap those nerves, and then I'm off to the boozer. Unfortunately, it's not as simple as that. I mean, this is we all follow these pictures. Oh yeah, that's how it's done. The nerves are right there. We can zap them with our ablation catheters and sort the blood pressure as well once we've done the coronaries, and that's easy. The thing is that that's not the anatomy. The anatomy is that these are sympathetic nerves. These are much further out into the hyal of the kidney, and so the future, I'm not going to go into all the slides now, is to do these renal ablations. We're about to restart. We gave up for a few years. We're starting again in next month. Terribly exciting. We're going to be right out here into the body of the kidney, down into the branches with our ablation catheters to try and zap these sympathetic nerves. So renal denervation was big about a few years ago. It's been very quiet, but it's coming back over the next couple of years, so watch this space. This is the Medtronic catheter, multipolar catheter. You can get right down inside the kidney, burn away. You say, does it do any damage? Well, not really, I think is the answer to that. I don't think so. We'll know in a year or two's time. Yes, it lowers blood pressure. This is another one. Don't worry about the data, it's fine. There's ultrasound technology, all kinds of fancy stuff. This is a trial that we were leading and we've just abandoned, using a gigantic ultrasound gun to blast the kidneys and hopefully damage the renal arteries. Nonsense. And so, the sort of thing you look back in your career and think, why did we ever think of doing that? It's horrific. Anyway, where is this? Come on. The flag gives it away. Framium. Yes, John, it's Framium. Well done. Framium, which of course has been one of the great setters for the last almost 80 years of the life events in cardiovascular medicine. And so let's finish with a little stuff about blood pressure and dementia. Now, it's one of the studies that Framium set up was to look at what happens with cognition and blood pressure. This is quite old data, right? And those people who didn't have high blood pressure, this is the emergence of dementia, okay? We don't want amputations, right, for diabetic, and we don't want dementia. We can deal with most other things. Those with hypertensive, far more dementia, right? So blood pressure and dementia are tightly related, okay? This is Whitehall, right? Whitehall, of course, has had these sequential studies of epidemiology as well for many, many years. And this is the 1985 study where civil servants, 10,000 odd, were measured. And you measure stuff, blood pressure, glucose, and cholesterol, whatnot, and then you just follow them up for decades and see what happens, all right? And so to look at the association between blood pressure and dementia over many years. This was published quite recently, and it's still an important finding. I'll just show you one slide. So what you see is from levels of blood pressure at age 50, to emerging dementia later in life, once you get much above 150 millimeters of mercury, you're up towards twice the risks of dementia. So blood pressure and dementia are tightly related. And for that reason, more than anything else, that's why we're going to aim at blood pressures of 130. Okay? We've rewritten the guideline for the west of Scotland, and we're going ahead of NICE. We're going to say we want 130/80 because of this. It's because of dementia. It's not because of heart disease and stroke. It's to try and reduce dementia in 20, 30 years' time. So we'll know if we were right or wrong in 20 years. This is some stuff that's just out from Sprint, from Paul Welton's trial. This is emergence. Now, this is an emergence of cognitive impairment and these brain injury MRI sub-studies. You can see that people in the intensive therapy in red had many fewer emergings of cognitive impairment and these little mini infarcts seen in MRI. And so that's even just over a few years. And so hopefully we'll be right. So having aggressive blood pressure lowering will reduce dementia for all of us over 20 years. So what I've said, it's a whistle-stop tour through hypertension. Lower towers are coming, they're here now, and they'll be probably lower again in a couple of years' time. Modification of lifestyle is crucial because it does make a difference. I'll just come back to the final point that home monitoring is the future for all of us. Ladies and gentlemen, thank you very much.